Great, terrific. Thanks, Joyce. So my name is Doug Brockmeyer. I'm one of 3 pediatric neurosurgeons at Primary Children's here, and I looked at the calendar, and with 2018, this would be the 25th year I've been on staff at Primary Children's. So feels like I almost know everybody in the audience. So if I don't know you, this is my introduction to you. And it's probably pretty weird that a neurosurgeon is coming to pediatric grand rounds and introducing a pediatrician, but I know that, and it's not because she's developed a cure for hydrocephalus. That is one thing we do know. Why Dr. Wendy Swanson is here is I heard her talk at a national meeting about 3 or 4 years ago, and I knew right then that she should come and talk to our group, both the Department of Pediatrics at the U and the folks at Intermountain. I knew that her area of interest, which is the intersection of media and medicine, and its intersection also with parent and physician relationships, dovetailed nicely with our missions here, and I knew that she would give an extraordinary presentation and a great learning opportunity for all of us. So as far as her background goes, she graduated from Kenyon College, honors in psychology, and then went to UPenn for medical school, and then her residency at Seattle Children's Hospital. She created a online tool called Virtual Handshake at Seattle Children's Hospital. She is the first person to bring a team together of surgeons and pediatricians in order to create a portal where parents can look at the visit before they arrive at the hospital. This is how it works. The parents log on. They get the information from the portal, and they work through the information as they go on. So she's also the author of Seattle Mama Doc blog, and which is the first pediatrician. Sorry, I'm really excited to be here. So I apologize. Yeah, I'm sorry, Wendy Sue. So she's the first one to create this blog for Seattle Children's Hospital and wrote the book Mama Doc Medicine. She has a significant Facebook presence and a presence on Twitter. And more than anybody else in the audience, she was honored to give a TED Talk, which is something that most of us have not been able to see. So I will turn over the rest of the time to Dr. Swanson and not belabor my introduction. Thank you.
Thank you. I gotta navigate this computer for 1 second, which is a little, hold on a second. We're gonna do this. So I always use a tool every day that makes me a little uncomfortable. I think it keeps it real because none of us like this evolving constant change management and technology. I'm so happy to be here. I do think this is the beginning of a great conversation. My hunch is about a multi-site step forward at using some new tools in pediatrics. And we have a lot of meetings set up, I think, to accomplish that in a new way of a partnership that developing digital tools across different sites, I'm starting to think is the way forward, not the development of tools isolated within systems themselves. So we'll talk about that as well. But to that card, I now feel a little intimidated by the 3 things you've learned, the 2 things that you got excited about. I think I switched those 2 and 3, and the 1 question you have. I hope you leave with an abundance of further questions. And I know from anything of being a middle school teacher in the past and being stuck in didactic lectures in medical education like all of us have been, that you can only learn about one thing in an hour didactic presentation. And my hope is actually this is very Myers-Briggs feeling, very capital F, that you are leaving here with an impetus or a feeling or a drive to make sure that you start to conform your priorities in how we serve. You know, we all have this incredible privilege to be part of families' lives and to witness vulnerabilities in children. And it is time for us to really change up both the efficiency with which we share what we know and really honor the profound transformation that has occurred with peer-to-peer sharing of information, with open access to information, and ultimately just the beginning of what happened in the 1970s with search on the internet and the connection to data and information. You know, I don't think there's a better time to be alive as a clinician. It's pretty sad that our work-life balance and our frustration with our profession is where it is, and yet we hold this incredible opportunity to be partners to those who are suffering in really profound new ways. I often start by talking about connection. That it's John Muir who said, you tug on anything in the universe and you find that it's connected to everything. And what digital tools have done, and there's no question that people are isolated. It's funny, I was having challenges with the internet last night and this morning here with the guest network through the university. And I was reminded again what it feels like not to have broadband internet access. We know, which actually is a funny thing, right? It's actually a good exercise to be kind of locked out. I could not update this presentation. There were a couple things I wanted to add, which I can show you offline afterward. But that's changing. Common Sense Media, a group who curates kind of how and what to watch on TV and what apps for kids to play with. And, they just published a slide yesterday that said it was just a few years ago that only 42% of lower SES families had access to broadband internet. This year, 72% of low-income families have access to broadband internet. It is changing. The excuse of exclusion, the excuse of you not moving forward in digital transformation, saying not everyone has access to it, that is over. We are here. Low SES has access to broadband internet. In fact, some people's primary access is their mobile device and smartphone. And it's time that we evolve as those who hold information and hold access and hold ideas for reducing suffering get there better. But we're deeply connected in new and profound ways. Doug, where are you? There. Thank you for the introduction. I'm going to give you as many kind of conflicts. I also have a master's in bioethics, and it means something to me. I think I'm full of them. I think we all are full of conflicts, but I want you to know kind of how I work and what I do. So at Children's, I'm the Chief of Digital Innovation. That's a job I've made up. I made up the Center for Digital Innovation back in 2013. It's all come really organically of just watching and thinking, being a mom, being a patient, being a cancer survivor, being an advocate to my own mother with a chronic cancer condition, and being a parent to 2 children, and being a primary care doctor. I'm Seattle Mama Doc, so that's the name of that blog. I was the first pediatric blogger or first physician blogger that we know of in the United States that blogged on behalf of a hospital. I convinced someone way back when to say, if I go put a shingle up on the internet and I start curating health information, that's not going to do anybody any good. If I do it at Seattle Children's in arm's reach of these subspecialists and experts, and in arm's reach of education and information and data, then we might actually have something. And by, I think, creating blogging and using Twitter and using Facebook and using YouTube as part of my day job, I think I've started to understand that that's actually how we make change, because we have to follow where the money moves in healthcare, as we all know, in such an uncomfortable way. So I write Seattle Mama Doc. I've written about 800 blog posts. I've been writing it since 2009, writing a blog about once every week. I used to blog 2 or 3 times a week. I used to do a video every week on YouTube. We've made thousands of those. And then now I run a weekly podcast as well. I'm on Twitter on a daily basis. I use Facebook, Instagram, Doximity, and WhatsApp. And I try to use all those tools, not because I actually enjoy them anymore so much, but because I really am still trying to learn how is it that we get information, how is it that we build trust and intimacy with those that we trust, and how do we search for information. I practice in general pediatrics now just 1 day a week with a group, the Everett Clinic, and I'm the chief medical officer of a startup company called Before Brands working to prevent food allergies. Oh, sorry, and I do television reporting with the NBC station about once a week in Seattle area as well. Okay, so I want to just give you some background. So I have a digital team that really helps me pull this all off, and they're extremely important and unique. So my lead program and product owner is a woman named Christina Berry White. She worked as a lead program manager ultimately in the IS department at Seattle Children's, and I was able to recruit her back. So she understands how the culture of Seattle Children's, and she's very beloved in the IT space. And she used to do things like we would update Cerner, and she'd go and we'd do a WIDE thing, or we interfaced, SurgeNet across the hospital. She went and did these large platforms. And for me, it was starting to become really, as I kind of built these novel and new tools in communication, I understood that what we really needed was a great producer. I went to Nike, visited their campus at one point, and they have all these different innovation groups. And one of the things they do is they always have a producer. I mean, like a movie producer, somebody who just gets it done. So Christina is my producer. Stacy Ulasha is an employee of mine who's a senior PR and communication specialist and helps me with all the media that I do. We had about 800 or 900 media placements with Mama Doc last year. And that's because she helps just support the phone calls and the negotiations there. But to get the word out, to translate healthcare, to get sound bites from a physician who takes the information and posits it hopefully in mom and dad language. We need a lot of support. We have a digital analyst, Stefania, who's the next one, who we also kind of stole from IT. But again, she's been analyzing typical and standard digital, and then we've been exposing her to all sorts of the innovation. And then our program coordinator, Jessica Blasco, kind of makes it all happen for us. So I tell you that because this team is exceptionally important for the ideation turning into true operational change. And that's the hardest thing. The ideas are easy. You all have them. The patients and family you serve, they all have great ideas. And frankly, I think half of the ideas that you build should be generated from patients and families, not just those expert patient and family communicators on your advisory councils, but earnestly thinking about how will you survey those who come into the walls, those who interface, those who schedule, those who talk. Can you ask them great questions? Can you create a listening project where instead of the dogmatic, paternalistic way that we create the solutions, we let patients and families help us too? So I love to start with Herbert Simon, who was an economist, and he was an economist that ultimately studied at Carnegie Mellon, and my father-in-law was in business school there way back when, and he's the one who introduced me to his ideas. But when you look back at Herbert Simon, in 1971, he coined the term attention economy, 71, before the internet. He basically said, what is most precious is your attention, and in our world, our patients' and families' attention. Whenever there's an overabundance of anything, there's a paucity or a dearth of whatever it is that's consuming it. So here we are with patients and families. I mean, when I have a 9-year-old son, and I have a just about to be 11-year-old. And when my 11-year-old, when I was pregnant with him, that was the beginning for me when Johnson & Johnson got in the game in a really smart way and launched Baby Center. Now, Baby Center was one of the original sites that said, well, okay, put in your end date of conception. Tell us when you think this baby's coming. And then every Tuesday, if your baby's due on a Tuesday, which he was, every Tuesday I'm going to send you a note that says, oh, here you are at gestational age. Oh, your baby's the size of a poppy seed. Oh, next week your baby's the size of a raspberry. Oh, started to push directly to me as a consumer, health information, guidance information, and actually positioned even their product placement that way. But that was the beginning in the parenting space when the mommy bloggers were starting and information was starting to share. But that's also the beginning of profound overwhelm for patients and families of information coming. It isn't that patients and families can't get information. It's that they're not necessarily sure of which information is the best. And it's our job in some ways to kind of curate that and use our attention and time together as best we can. Pew Internet, basically, it used to be called the Pew Internet Life Project, but the Pew is ultimately a nonpartisan, nonprofit organization that looks at kind of what's happening in the world. A great place for you to go if you're ever creating a deck or learning about how the consumers think about digital, how they think about politics, how they think about race, how they think about an equity lens, anything else. But Pew is a great place to go to help understand how do human beings across the United States live, work, think, sleep, and use devices. They have found since 2010, this is not new, 80% of families within the last month have searched about health information online. And it's, of course, not on behalf of ourselves always. It's because we're nosy about our neighbor, or we're doing it on behalf of someone for which we're providing care. 2 billion people on the planet are using Facebook actively. That's not logging in an account and jettison it. That is earnestly using Facebook to communicate, think, learn, share, buy, sell. These tools are not going away. 2 billion people on the planet, larger than any other kind of population, are living in a space that uses the same colors, that uses the same interface, that uses the same experience. Like the largest nation in the world, they're using Facebook to communicate. 2 billion people are using Messenger to communicate in that way. 250 million people are sharing photographs of the United States and stories. Stories are just the ones where I put up my phone, like I could do it right now, and I take a little live clip of where I am. 250 million people are taking live little video clips of where they are. And at the bottom, I think what's most important is thinking, so this is from the summertime, this is from July, but at the bottom, it's this virtual reality and augmented reality. And we were introduced to it in pediatrics with Pokemon Go, right? Kind of lame, right? And a little bit creepy. But at the same time, right, and we had those weird kids that were like, breaking their arms because they were on a skateboard and they plowed into a wall, and it was like this very pediatric story. But at the same time, what's happening is that people who are really smart, who want to sell an idea or sell a product, are going to embed your reality with different digital connections. We could do that too. At the park, you could have a digital or virtual reality about what do we know from the orthopedic surgeons. Well, we don't want to go out on a slide with our grandma at the same time. We know that's why we get a lot more injuries in the lower and upper extremities. Who knows what else we want to talk about at the park? Who knows what else you want to talk about in a prevention strategy in a grocery store or in the school system? Or maybe how and where and how up to date is your population? What drew me to the public space was vaccine hesitancy and the loss of voice for the science and safety on vaccines. What if every time you went into school, you were reminded that only 82% of the population at school had a flu vaccine? And what if then someone had a flu campaign, and you actually could walk in and you'd have a little bloop that said, oh my gosh, you're up to 89%. What if moms and dads and school nurses ran the urgency for vaccination and safety and a community immunity as opposed to us? They're going to do a better job than we are. So people are critical of the parenting world and the digital natives rising up, that they're too online, they're too stuck, right? We're too distracted, we're not enjoying our kids, we're disconnected. And I'd say we mess up all the time. These devices, and we know the power of dopamine from getting a message, right? Drives people off the road, right? Increases our this is the first time that we've we've increased vehicular deaths across this nation as opposed to decreasing them because of our incredible use of seatbelts, right? We're distracted, we're connected, we're committed to getting information, and we're wired biologically to love these devices. Parents go online and share. Sharenting is kind of this concept of going on and sharing a picture of your kid. This is done by C.S. Mott from University of Michigan. But if you look at this data, this is how parents and families can actually feel better. What are the common topics that they sharent on? Well, sleep, nutrition, discipline, daycare, and behavior. That's pediatrics. And the benefits, 72% of parents say that when they go and share information about their kid online, they feel less alone. 67% say they get advice from other parents. 62% say it helps them worry less. Caucasian Americans, for the first time in this country as well, have a decreasing life expectancy. Fortunately, Hispanic Americans and African Americans are increasing their longevity and life expectancy, but Caucasians, it's deteriorating and decreasing. That's secondary to 3 separate diagnoses that I would track back to feeling alone, worry, isolation, and not having community, and that is fatty liver disease secondary to alcoholism, opioid overdose, and suicide. Caucasian Americans are not living as long anymore because of those 3 diagnoses. And parents tell us, they go online and share pictures of their kids, they feel less alone. 95% of Americans have a cell phone that's defined by being over the age of 18. 77%, and that is rising, that's data from the summer, have a smartphone. So microcomputer in your pocket, you can, think of what it's doing to our impatience with getting information and an answer. We talk a lot about service in healthcare. We talk a lot about wait times. We talk a lot about being available. And yet we know what it's like to run and get behind and be, 2 hours even behind on a bad day. But when you can go online and in a couple of minutes find great information, and sometimes it's great information, right? We have to think really carefully of what we're doing. Now, 7% of Americans are dependent on the internet from a mobile device. 66% of people are checking their phone in the middle of the night. 44% of people are sleeping with their cell phone. This is the way we live. Now, I think this is old data, 2013, but down at the bottom, 1/3 of Americans go online and self-diagnose. We know that's higher and higher. If you're college educated, 55 to 60% of people go online and self-diagnose. And I'm here to tell you, I don't think that's such a bad thing. 77% don't start at Intermountain, don't start at Primary Children's, don't go to Seattle Children's. They don't go to you first. They go to a search engine and they search. Of course. If you're going to look up, what's the price of diapers, or, oh my gosh, there's that new drone I really want to buy, or do I really need antibiotics if my throat hurts and I have a rash, right? Why wouldn't you do that? But the reality is that, smart companies have come to the game. So probably the smartest brand in healthcare, if you ask me, is Mayo Clinic. Now, part of the reason, and they're number 1 in the U.S. News and World Report most years, and part of the reason I think Mayo Clinic is so good, they provide quality care. We also know it's really expensive at Mayo. But at the same time, they were smart enough in 1995 to launch mayoclinic.com. So they took a nonprofit organization and then they went and did a .com launch. Now, what they did as well about 2 years ago is they made a deal with Google and they said, well, let's take all of this online content, for which they are the kings and queens of online content, right? You Google healthcare, right? You're going to land on a Mayo Clinic link. Their search engine optimization is phenomenal. But they partnered with Google and they said, well, let's take the 1,000 top diagnoses by, big data. They aggregated and said, what are the number 1,000 top searches? And then let's create a right side margin piece of content. I mean, do it. Like, get your phone out. Search up pink eye, conjunctivitis, bronchiolitis, UTI, bladder infection, whatever you want to call it. Search it whichever way you want. And on the right side, there'll be data and information, epidemiology, potential cure, reasons to seek care, and reasons not to. So what we're finding online when we're trying to self-diagnose is not so bad. And even that data in 2012, 2013, when you followed people who self-diagnosed online, most people go into a care provider if they're really concerned that the lump under their neck is lymphoma, or if they're concerned that their child really does have an autism spectrum disorder or a communication challenge. They go in and seek care and help. And 40% of the time, their diagnosis online is right. That's going to get better and better and better. They're going to need you, not less, but in different ways. People go on Facebook and they use their tribe to diagnose their clinical problems. They don't do that when they have a brain tumor, but in the old adage is always like, oh, if you Google your headache, you have a brain tumor. Well, sometimes you do have a brain tumor, right? Not very often. And most of the time, headache can be managed, but it's really complicated. It's a really complicated problem. But parents will go online, they'll ask their tribe, what is this? This is an actual parent on Facebook asking about this. Is this a heat rash? What this is? And the levels of engagement that people will do for their friends and family are pretty intense. But how we position information online really matters too. So, when I think about vaccine education and science education and information, 1 in 10 families don't follow our recommendations. Well, another way to say that is actually 90% do. We know 90% of families are following AAP and CDC guidelines on immunization. But we know that how we make these decisions is not so much based on us, those clinicians and that dyad of patient-doctor or provider-patient or patient-provider relationship. 95% of families, this is a study from a sociologist and anthropologist at the University of Washington about 2 or 3 years ago, but she studied ultimately people's, not social networks, but their people networks, who you talk to at work, who you talk to at school, who's in your family. 95% of them talk to those people when making a vaccine decision. So it isn't just the pediatrician they're talking to, of course. Now, she broke them up into what she called conformers and non-conformers, those who followed the schedule, those who didn't. Now, those who followed the schedule, only 13% said someone in my people network told me not to vaccinate my kid. Those who don't conform, those who delay, that 11%, families who delay vaccinations, who make up their own schedules or refuse vaccinations all entirely together, which is only about 1% of the US population. They get a loud voice, media makes them appear very big, but it's only about 1%. 72% of those nonconformers, though, said someone in their network told them not to vaccinate. Are you in the network of the patients and families who need your education and information? Because a very loud minority online, this is a cloud-based data that came from Wired magazine in June, when Dr. Richard Pan from the American Academy of Pediatrics, a state senator from California, put forward State Bill 277, where he said, this stuff really changes trust in healthcare, really changes the opportunity of building trust with you as a provider. When people legislate vaccine decisions in any state, the only states that we've got that right now across the board are Mississippi, West Virginia, and now the state of California. But they're basically saying you can't, unless you have a medical exemption, you can't go to school anymore if you don't vaccinate your kid. That's a very paternalistic approach, and yet because we know lots of vaccine exemptions come because of convenience factors, it's been a way forward, and this really came out after the measles Disneyland outbreak with measles that really kind of helped the public understand vulnerability in infancy, vulnerability in unvaccinated communities that way. But a very small vocal minority online can change it to the point that they used a hashtag on Twitter called CDC Whistleblower and a hashtag to almost overrun public opinion about that when that went through. It went through, but it was tough. And it's been successful. So this is just a quick little Instagram clip of really looking at the transformation. Red is bad, let's say. Green is good. So if you look, what happened even after Dr. Pan put this bill forward, we're finding vaccination uptake is changing across the state of California. The American Academy of Pediatrics even made a statement a year ago that they think states should go forward in the same manner. But I'll tell you, I look at this like a little bit more holistically. I really care about vaccine protection. I really care about personal liberty. And I really care about how patients and families build trust with us. How is it that we get them to believe in what we're doing? Is it actually just legislation? But celebrities are coming to healthcare in profound new ways. And I'm not going to play you these clips, but Jimmy Kimmel has gone to bat because of personal experience with his son with congenital heart disease. And ultimately his experience and the tragedy that he started to incur when he realized with ACA reform that there were parents like him that were not going to get the care that he got. People are coming to play, to bat and fight. But it is not disconnection, it is overwhelm in some ways. And how we think about where do patients and families engage with us, How do they learn about the health condition in the minute that they worry about it? My most read blog post, which gets read over 10,000 times a month, is a post that is just called, "Why Do Toddlers Wake Up at Night?" And when you go into Google Analytics overnight or in the middle of the day, I can watch in live time. If it's noon here and it's midnight in the Philippines, people are reading in the Philippines. If it's 3 in the afternoon in Seattle and it's 11 o'clock at night in England, they're reading it in England. So parents aren't reading about why toddlers wake up at night at 3 in the afternoon. They're reading about it at 3 in the morning because they're frantic. So how are you getting the information and the connection of what you have and what you know when someone's making a decision at the time when someone is curious because they're going to go online? And we do confuse experience for expertise, and I do vilify Jenny McCarthy, but that woman is a smart woman who took a story, had a tragic event in her life where she felt that her child stopped communicating with her. She believed that there was a vaccine that caused that problem, and she changed our job for the rest of, I think, our time about building trust in science. But people confuse her experience. There's a clip actually when she interviewed with Diane Sawyer in 2010. Study was published in Pediatrics about looking at gluten-free diets and unfortunately, their non-ability to transform behavior in kids with an autism spectrum disorder. So it was a negative study, which, as you guys know, is hard to get published. Good data, but instead of interviewing those who published the paper, they interviewed Jenny and she talked about her anecdote. So we do go online and confuse experience for expertise that you house, but not all the time. I think if I'm going to compel you to do anything different, this is the moment. So you may, glossing over, this is the moment. This is data that was presented in 2005 at the National Immunization Conference at the CDC. But I love this, and I think this is our call to action as clinicians living in a digital age. So when we're not worried about things, patients determining credibility. If you're going to decide that I'm worth my weight, I'm an Ivy League trained pediatrician, I'm board certified, hopefully I know what I'm talking about when I'm talking to you about your diaper rash or your ear infection, or hopefully your vaccinations, or something really scary like a chronic or life-threatening or life-ending disease. But if you're not that concerned, if you're going in, you only go to the doctor for 2 reasons, or the nurse practitioner, or anybody else. You go because you're in pain, and you want it to go away, or someone you love is, or you go because you're anxious about something. Even wellness and prevention visits are all based on that, right? We've created and drummed up an anxiety that you have to do these certain things, and we've mapped out why we do preventative healthcare strategies for kids and vaccination schedules on that. But you go in because you want to just make sure everything's okay. See that your kid really is growing, and that when they only ate 2 bites of strawberry and air yesterday, they still grew, right? But you come in, you're not that worried. You look at me and you say, you are board certified. You work at a good institution. My competence and expertise is about 85% of what determines if you think I'm credible when I'm giving you information. But if you're scared, which most of us, when we care for you guys in a tertiary care institution like this, everything shifts and changes. So here I am trying to develop credibility, but now this parent and family is worried. Now this caregiver, now this wife or husband or spouse or partner is worried. And how do they decide if I'm credible and what I'm telling them is important and they're going to adhere to what I'm doing? They're going to stay with me. They're going to keep a loyal relationship with me. My competence and expertise is about 15%. And look, if I show that I listen, I know you know this, but if I show that I listen and I care and I'm empathetic and I demonstrate an integrity and commitment to honesty, that's how they're going to decide if I'm credible. You don't have to do that all in person all day long. And I think, in fact, since I went online, and I started sharing stories, and I started taking evidence, and I started sharing an anecdote on top of what data was important, I think my relationships profoundly changed. My practice closed immediately as well. So demand goes, whoosh, right, like bananas, when you're willing to be passionate and share what you care about, what you know, who you are, and why you go to work. So our new set of responsibilities, I got to speed up, you guys, because I've been rambling. I'm going for it, Doug. I'm going to get through it. But I have a lot to say, but we're going to go. So quickly, right? Parents have very little time with this. This is in primary care medicine. This was exit interviews of patients and families at wellness visits back in 2011. But, we get, we see parents and families for about 11 to 15 minutes. And I'm supposed to talk about all of the parent and family concerns. I'm supposed to keep them happy and keep my Press Ganey scores really up. I'm supposed to keep my staff really happy while I'm doing that. I'm supposed to do a complete physical exam. I'm supposed to talk to them about vaccine concerns and safety, talk about what's going on at school, make sure that we actually are joyful and excited, and I'm watching and observing the child, and I get 11 to 20 minutes to do that. So this one-to-many communication is kind of been my experimentation. Ultimately, I go to pediatrics and I see people one at a time. I can see 20 or so kids in a day. When I go to a blog, I can potentially reach thousands of people. When I use media, I can do a couple of things. I can funnel information and listen. So when something's going on online, I can take a search term on Twitter and I can just say, I don't know. Should we talk about firearm safety this week? Because it's a horrifying nightmare that we're going through in this country, and we're all scared. And although we know, right, that suicides are the #1 reason for death from a firearm in this country, we know that mass shootings are dramatically destabilizing us as a population. I mean, who in this room doesn't kiss their kids goodbye in the morning and think about what might happen today anymore? I think about it every day. It's complete distortion of the data. The biggest concern is keeping my kids' mental health safe and making sure they don't have access to a firearm. But how are we going to listen to what people are saying online so that we as clinicians and trusted people in those lives who have credibility with so many people even think on how we message it? So if you're thinking about social tools or you're thinking about digital tools, you better be thinking really carefully as a clinician, like how are you using them to listen, not so much how are you using them to talk. And that's been the big lesson for me in social. And we talk a lot in trainees with medical students and residents about this digital footprint. And I would bet that your employer has scared the living daylights out of you for what you're going to say online and who you're representing and what you're doing. But I think we have to think really carefully that in this time of needing to create loyalty as the consumer space is changing dramatically, needing to be relevant in patients' and families' lives, this is not about a digital footprint. This is the opportunity of a digital fingerprint. Who are you? Do you have a LinkedIn up? Have you put a photo up on it? Have you told people what you care about and what you know, how you trained and how you've kept your board certification up to date? Everybody should be Googling themselves every quarter or so. It's not narcissism, it's just smart. You should know what you look like online. So quickly, and Doug mentioned this, I write this blog. You can check it out. There's, like I said, 800 or 900 posted on it. But I partner typically with all sorts of experts at Seattle Children's to do that, and governmental organizations and nonprofits in the region. I also do a podcast now every week, and I try to do content that people kind of talk about in the exam room, but I bring in different experts. So yesterday I made about 4 or 5 podcasts, and I brought in an expert. We talked about concussion. I mean, the concussion care and guidelines is changing constantly, and CDC with Heads Up has helped the population understand it. But again, we've vilified sports in a way that we can change. We've scared parents, right? There's all sorts of clinics popping up, and yet clinicians that sometimes don't even know, is it really brain rest? Well, no, it's not anymore. Now we actually think it's quick, make sure to pull a kid out of a game, give them 24 to 48 hours, and then it's rehabilitation reentry, right? So how is it that we're kind of getting information to parents and families, and where do they go and learn about that? But, you know, I do partner with experts, and I do try to talk about my own life experience. So a lot of people will also talk about really fastidiously, you know, taking your personal life and then taking your professional life and making sure none of that overlaps online. I take a different approach. I mean, when we're in the exam space and we're in a clinical space with parents and families, we talk to them like peers because we're human beings. We're not robots. People do care what we would do with our own kids. And it is our obligation, and it is ethically just at this point to be passionate about things that families need to know about. Pictures do tell 1,000 words. And so parents and families can learn a lot. At Halloween time, for example, right, of, you know, these vitamins or these ingestions, when we think about risks for toddlerhood, for example, ingestions still kind of rank at the top. So how are we thinking as systems to carefully use these different platforms, share information, not just to market your services, but to provide the care that you want? I mean, imagine if you're a general pediatrician and you know that at the 6-month visit, you know what you're going to talk about. You're going to talk about food introduction. You're going to talk about vaccines. It's the first time we give a flu shot, so that's going to take up a little bit of time. You're going to talk about the sleep cycle, and the brain is actually fully mature at how it goes through that. But babies are learning to sit, they're learning to eat, they're maybe transitioning to daycare. There are all these different things. Most of it is not personal to that family. What if you had a little curated list of education that you gave them before they came in for the 6-month visit that you could see on the back end, actually they'd read or not, so that when you started the visit, you could say, have you reviewed all the stuff I needed you to say? Are you still in the bucket car seat? Okay, great. What questions do you have today? Right? How different the visit really could be. This is just an example of, like, you know, these memes go online where people go kind of banana brains, where they're like, you know, this book basically is the problem to all my child's sleep. It's this magic book. I read this kid and my kids go to sleep. Well, like, not really, right? Like, you know, we got to do a little myth busting too. So the other thing is, can you think about whenever you're making anything, Intermountain makes something, Primary Children's makes something, you as a department make something. How are you partnering with people? I mean, if anything, I'm learning that don't do this alone. There's no reason to do this alone. In fact, the more you do with other people, the better credit your institution, you yourself, and your patients and families will get from that. This was a journey where I joined with the Academy of Pediatrics after this measles outbreak, and I said, you know, everyone goes on Twitter and they do these things called Twitter chats. Completely impractical, where you sit on Twitter for an hour and you kind of share stuff and you have these little conversations and people coalesce and they try to have them. And I said, why don't we take really busy clinicians and just dump and populate the internet with fact about measles? Because there's all sorts of memes going on and all sorts of myths about it. The mommy war started up of people saying, well, if you just breastfed your kid, they wouldn't get measles. I mean, it was just all this hoo-ha. So I kind of galvanized through a number of pediatricians who are working through the academy, and we said, well, let's just do what I made it up because I said, let's just do a Twitter storm. 10 minutes, dump stuff on Twitter that you think is fact-based and use a hashtag. Within 10 minutes, we had 20 million impressions. So you can organize, like the anti-vaxxers actually, you can organize your information. And this is just kind of cloud-based information of what happened at that time from that tweet activity and the amount of people that were reached. There's 60,000 pediatricians in the AAP, and yet think of how much media and time and messages you hear from a very small minority of people who don't agree. Now, these are some examples just recently I captured from ultimately the kind of political activity. And I'm not asking you to get politically involved if you don't want to, but what has happened across the country with ACA because of Pediatricians has gained national, Pediatricians is the name for, it's a little bit creepy and infantilizes this, but I'm not the biggest fan of the term, but those of us who use Twitter for advocacy, education, and curation, but using these hashtags with the American Academy of Pediatrics or with local groups or your Department of Health has actually mobilized and changed voting. So we know that we've had significant influence this fall in a way that has never happened before. Some data that's very small from a recent slide at high levels of the Academy, they know that using the Keep Kids Covered hashtag, there were 28,000 tweets that at the time when ACA was really going up for voting went through, and they reached 27 million people on Twitter doing that. So those are individual clinicians and voices going in and sharing what they want to have happen to protect kids' access to healthcare that way. There really is something magic about doing one thing at a time. And the neurosurgeons and neuroscientists and neurologists tell us, of course, you can only do one thing at a time. So I'm not asking to make your life more miserable, and I do understand that we are really burnt out. So this is not about you being more on your devices or being on 6 social channels like I am. It is really thinking that we're pretty burnt out and dissatisfied, and part of that is our lack of connection to our purpose, I think, to really doing the work that we want and getting rid of the work that we don't, and digitization can really help that. And as just a quick reminder, right, we are kind of a suffering workforce. I mean, this statistic from 2015, that even nearly 30 residents have symptoms or a diagnosis of depression, meaning that just when you begin this journey, this is already overwhelming and challenging. And the asks from administrators and from technologists, right, is that we keep changing up what we do. And so I just want to be really clear. I do keep that in mind when I think about these things. AMA is one of the only groups that's gone forward, and I take a little bit of, I mean, I'm a little political, but I mean, AMA makes me really frustrated. And I mean, when it comes to pediatrics in particular. But, you know, they talk about kind of policing other people online, separating your personal and professional lives. And basically, you get to decide who you are online, just like you do in real life. You get to decide what you share and what you don't. It appears to the world that I share everything about my family, and yet I share hardly anything about what's going on in my life online. It just looks like I do. So I think you get to decide how you do this. But these new responsibilities are real. And you know, Utah is one of the world leaders here, really, in thinking about transparency, in part because of Vivian Lee's leadership that came about when she thought about using Press Ganey and digitizing that at the University of Utah, which, you know, this is you guys. But ultimately, does everyone know the Open Notes Project? Okay, so the Open Notes Project was ultimately, Tom Del Banco, who's a professor of medicine at Harvard, started this movement, and he basically said, you know, patients and families deserve not to do online scheduling through electronic health record. I mean, they deserve that too. But they deserve a lot more, which is they deserve access to the notes that we write, the access that a clinician writes, the notes that nurses write, the nurse that your phlebotomist puts in the chart if you want, or a physical therapist. And actually, if you look at the data very clearly, not only do people deserve that, and it varies by state where your legal right is, right, of course, but the complexities, right, of non-interoperability between one institution and another is one of the banes of our existence, right, in healthcare. You know, my husband's a pediatric radiologist, and the number of redo scans that we do because we can't get to the right data is preposterous. It's preposterous waste, and it gets and verges actually on what I would call fraud at some point. But that's because we haven't created the technology to put the digitization in patients' and families' hands so that when they walk out of anywhere, they should have their ultrasound, they should have their radiologic. And Open Notes basically said, if actually we do what's right and put the patient in control of all the data, then wherever the patient is, we can get into the patient's record as we need to and as the family would want to. So Open Notes started as a movement. It was funded ultimately with some national grants and then went forward. And ultimately what they're finding, of course, is that The transformation to open notes, so we did it at the Everett Clinic about 5 years ago, and our chief information officer calls it a non-event. So there's all this hesitancy, there's all these breaks that go out, there's all this concern that this paternalistic, we hold this data, we can't release records early, patients will ask the wrong questions, they shouldn't read my note because they won't understand it, and I might have to document things differently because my patients and families might see it. Well, good for you. I mean, I say, learn how to document differently so patients and families can see what you write. And if you really have a case of suspected child abuse and neglect, or you have a case of psychological social harm that you think might be problematic, there are rules and stopgaps for that. But we have to change this differently. I mean, what we know is that these open notes results, so some of this was piloted through Kaiser, some of this was piloted through the VA, and some of it was done in the Pacific Northwest region. But what we ultimately know is that it isn't that people go and check these notes for your accuracy and get more angry with you and go on their Yelp or their, online review and criticize you. In fact, 60% are better and more adherent to the medicines because they understand the note. 75% say that they feel more in control of their disease and condition if they have access to the doctor's notes. 75% say they have more control, feel more control of their disease or condition. And 85% of people say they don't ever want to choose a doctor who doesn't have open notes once they've had it. This is where we're going. We're not going back, and as you guys know here, right, the transparency lead I think is the way forward. That this Press Ganey Live, as you guys know, at the University of Utah, do you guys do that here at primary? Are your Press Ganey or satisfaction scores live? So that like a patient family can look at it and see it before. Intermountain it is, yeah. So, I mean, that's the way forward, and that can be intimidating. And I work for 2 different healthcare organizations actively as a primary care pediatrician, right, in one, and at Children's as an executive. But, the experience and the tonality of them is very different. So at every clinic, it's been open, but it isn't necessarily open out to the public. But this is where we're going, the kind of Yelpification, right, of healthcare that way. And I love the concept of using a SWAT team to just help providers that have low scores, as opposed to hiding that there are providers that have low scores, because everybody wants to do this better. And not all of us can actually do it all that well. The reality is that we often say we're going to put patients at the center of care. We've been saying that for a decade or two. And the good news is that technology is making sure that patients are just at the center of care. The quantified self movement, right? Me tracking how much I move, what my heart rate is, how much I eat. We know typically activity trackers and things. Now, those don't probably need to integrate and populate into our electronic health records. But this is a slide as a reminder to say, we can sit around and keep saying we're going to put patients and families in the center. But patients and families will be in the center more and more as they can get their own data, as they can consult and review with a telemedicine doc, an expert from anywhere across the world over time. And so it's our opportunity to think really carefully. This is the future. So this is a company that was just acquired by Google. It was created by researchers at the University of Washington. It is accurate. 80% of kids have neonatal jaundice, right? In this country, the morbidity and mortality is exceedingly low. And yet we bring and trek kids into the office all the time, into these sick waiting rooms, when actually you could optimize this by having a whole system of parents have an app that after the newborn time, they could take a picture of this baby, tell us what the jaundice level is. We could actually have a home-like scale, right? These moms could know on a daily basis if the breastfeeding is going well or not, and this baby's gaining, and we don't have to bring these kids in. I'm going to show you some information about Tonic, which is a basically iOS or Apple or iPad device where you can do survey tools. This is a reminder that these gadgets that are out there in the world, they're ultimately not just gadgets for parents and families to get this temperature, but you can look at a population based on where is fever coming. So like flu trends, right? The Google Flu Trends has started to be able to predict where is influenza washing over the globe based on search. We're going to know at population levels how many kids have fevers in communities and things and actually target for that. But artificial intelligence is coming fast, and there's a lot of stealth work going. Amazon Alexa team partnered with Boston Children's to make an app where, how many of you guys have an Alexa in your house? So the millions and millions now. We have a couple in our house, and I kind of experiment with it and watch how my kids interact with it too. But ultimately, it's kind of like you could say, hey, Alexa, what's the dose of Tylenol? My son weighs 15 pounds. Right? She could just tell you that, right? You don't have to have the mommy call in the middle of the night. Or, I'm worried about this, Alexa, tell me. So there's that. But then we can take it a step farther. I mean, some of these dots are like $30, right? They go on sale on Amazon Prime Day, and they're $30. Well, what if we had these in the exam room and you'd programmed it to actually follow up your clinical pathways, and a family and patient could say, what do I have to do for discharge? And Alexa would tell them. What was still pending to do that? Where's the cafeteria? What's for lunch today? Or what if you created patient stories so people felt less alone, and you could say, hey, I'm in here for renal transplant. Are there any patient stories? And one mom could talk to another mom through an artificial device, right? So, CellScope is a company that's done very well middle ear exams that parents and families can do with their own smartphone, sends a video clip to a pediatrician. Since we don't want to write for antibiotics in the first 48 hours anyway, then we can just encourage use of over-the-counter pain meds for that. Uber is coming to healthcare. Uber Health is rising. Circulation, launched out of Boston Children's. Getting and moving people around health systems is a product of Uber itself. But Uber a couple years ago said, okay, well, let's do flu vaccinations that way. And it's like throw a book club, hire an Uber driver, and she'll come with a nurse. The nurse Uber driver will come to your house and do flu shots for everybody at book club. I mean, these are the people coming to healthcare. And this is, I think, what we kind of feel like. Just sitting here waiting for Facebook to go away. 2 billion people are using it still. Okay, so when my brother graduated from high school, his very curmudgeon-y old history teacher gave the commencement address, and I've never forgot it. And this was his line: be a willow, not an oak. We can change who we are and not be so stodgy. So virtual handshake, which I'm not going to go into, but we'll certainly talk, and I do think there's an opportunity for us here, is this tool that I ultimately built that allows basically for what we call asynchronous education. The idea that me as a primary care doctor, if I refer in a kid for an inguinal hernia evaluation, parents and family are freaked out. They leave the office, they call everybody. By putting in 5 codes, the diagnostic code, the doctor they're going to see, they get invited to a place where they land in, and it says, Hi, Susie, we're going to see you next Tuesday with your baby Jamie for possible inguinal hernia exam. Here's the doctor you're going to see. He makes a little dopey, direct-to-camera, YouTube quality. This is why I go to work. I mean, what surgeons say when they tell you why they go to work? It's amazing. It's not that I went to med school here. It's not the credibility thing. It's I get out of bed and leave my kids because all children deserve a chance at life in a different way, right? Those kind of things. So parents and families stream that. They can read links from maybe your health system, not just my health system, but the best links. Curate some information about what is an inguinal hernia and what do we expect. They can invite the mother-in-law in Iowa so she can see it too. So when she said, like, who are you seeing? Where are you going? What's happening? She can see the doctor as well. You can ask a question. You can connect that way. And then after the visit, you can dump a bunch of information into that virtual handshake as well. So we've piloted that in the surgical space, in the gastroenterology space, and in the pain clinic, where you schedule an appointment. Families and patients get access to a private community. They can invite anyone they want. We had one family invite 27 people from Alaska because they were in Alaska, so they were kind of a remote. They invited all sorts of people in there. They can capture and send videos. So for New Seizure Clinic, we allowed families to send us videos of seizure or seizure-like activity to the first seizure clinic so the ARNPs could review that before they walk in the door to see the family. Imagine if we actually listened to patients and families like how they send to their friends, and we said, you sent me a video and I'll look at it before I walk in. Not wait and take time and after and blow you off, but that video that you took of your kid means a lot to you. It might be the reason that you came in for the visit. Then one click kind of figure out these ways on the way out. Our big challenges with virtual handshake is it's been underfunded. I haven't had a big team. It needs to be rebuilt. I mean, I'm just gonna be honest here. It's a great idea. There's no question that you could decide what you want everybody based on diagnostic codes to see or think or learn about you before they come in. And you could then hand deliver information to the people they care about, including the school nurse or the primary care doctor or anybody else after the visit. And so then instead, if mom is the only one who could come to the visit during the day and she gets home at night and dad says, what'd the doctor say? Since we know we only remember about 20% of a visit, mom doesn't have to do all the translation. Maybe you could do a video recording during the visit, throw it to the handshake, and dad could then review that at night, or the partner or spouse of that mom could review it at night. I'm going to breeze through quickly what we've done with Tonic. And this, I love this platform. I think there's a lot of hope in, does anyone know this platform? Has anyone used it at all? So this is basically trying to get rid of the clipboard environment, and we've been using this at Seattle Children's in very diverse ways and in innovative ways as well. So we've used it kind of out of the box, which is ultimately designed to say that clipboard information that you get, instead of doing it on a piece of paper and asking patients and families the same thing and then scanning it into our electronic health record, can we put it in a playful interface on an iPad or on a browser with someone before they come or on their iPhone before they come? And can they answer all these questions, and then can it remember you? So we use it for all of our ambulatory diabetic patients now in their every 3-month visit. They tell us what their sugars are like, what the activity is, and it remembers them. So they say, last time that you told us you were on the insulin pump, this is what your sugars had been. What's been the challenge since we saw you last time? So we remembers the patient. It's interfaced with our scheduling equipment. But we've also used it to build out some innovative curriculum in the transplant space. So now for every patient and family who has a liver transplant or a renal transplant that comes in, we basically said, we got to put expert education in the same place that we put peer-to-peer. So we interviewed patients and families talking about all the context of what happens right after transplant. How do we actually take what the Bedside pharmacists were doing teaching about immunosuppression, about anti-infectives, about what was going to happen in the next couple of months. We digitized it into a curriculum on this place so we can ask questions from patients and families, automatically score tools and intake questionnaires in that space. But I can also push YouTube videos where a mom talks about rejection, of how scary it sounds, but also just how you manage it when it happens. Connect that mom with another mom right after a transplant. We built graphics using like a $2 app on an iPad, this thing called Explain Everything, where you can create a little video by taking a PowerPoint presentation and making a little audio file over it. And we explained to parents and families how they were going to use these meds over time. We made little videos explaining how the drug labels worked, how patients and families are going to be discharged about that. We then put all sorts of kind of teach backs in there with health educators have really taught me, like, it is a valuable way, of course, to understand if people are learning. And then we asked people, like, did this help you feel more in control of your disease or condition? We put images of the drugs that they were using. We did explanations, and we had about 14, 15 channels. Then we said, okay, let's digitize the whole thing. So instead of saying, let's just digitize the time right in the patient and family's experience after transplant. Because what's really amazing about this is a 4-hour curriculum. We asked patients and families when they wanted it, and they said, before I leave the ICU, I want the iPad. They were watching 4 or 5 hours of video in the first 24 hours of getting the iPad, and they weren't watching it at 5 when the pharmacists are available. They were watching it at like 10 or 11 at night when their kids were sleeping, and there was time to learn. Right? So can we actually serve our patients and families with the stuff that we say over and over again all day in a way that's convenient? And actually, it's okay if patients and families like the iPads better in that way. It doesn't make us bad teachers. It doesn't make us bad communicators. They may like to learn this way, and this might be the way forward. So now we've built out a whole curriculum that we're going to try to launch nationally across liver transplant centers that ultimately is using and explaining consent. You can do informed consent and written consent in the app itself. Then we're doing and supporting peer-to-peer support during listening. Then we have this bedside teaching after transplant. And then we've digitized all sorts of things after the experience. But we asked patients and families, this is a really small number, as you can see, but we asked them after using this in the liver transplant space, and we're looking at tacrolimus levels, we're looking at basically rehospitalization and readmissions to try to see, does this actually, of course, prevent us from kicking these kids back into the hospital? 80% agreed or strongly agreed that they felt more in their child, in control of their disease or condition by doing that. Would this be useful to me and my family after I leave the hospital? 89%, of course, say, yeah, I agree or I strongly agree. I plan on sharing this educational tool with other caregivers. So we made what was called a nanny chapter, where we said, like, mother-in-law comes into town and she treats you like you're a crazy person because you won't go on a date night because you have to do the tacro at 7:30. Because that's real. This is what parents told us. Like, people think they're crazy, but we make them crazy. We say, you can't miss that window. We're going to do a peak and a trough. You can't miss that and keep that organ healthy. And then they go out and their population tells them that they're lunatics. Well, we made a chapter for the people that call them lunatics so they could really understand, why is it that you have to really adhere to that 7:30 in the morning and 7:30 p.m. dosing? And then I think one of the opportunities of this across systems is that there's a researcher that had specifically created a quality of life score out of Toronto, this woman, Vicky and it was specific for this population. And the great news was, I said, well, Vicky, if we digitize the scale, which is complicated, but we digitize the scale that she was doing, it self-scores in the app itself. And then I said, you could just stream a video explaining what the score means. The person who made the scale, not even dependent on us translating it the right way. So can we standardize meaningful exploration and communication by saying the person who knows it best can say it, or we can have our own team say it too in these apps. So we're exploring that. I think this is true a little bit. You can study the pie chart, which are hard to read. So this is the place that we're moving forward. I'm going to buzz through this because I want to give us a few minutes for questions. This is ultimately a bunch of information about how to use social tools, which I don't really care if you go on Twitter or Facebook or Instagram. I'm not suggesting you have to be a public physician writing blogs like I do, but I do think that you need to think carefully about how what you know gets to the people, patients that you serve and care about, and how when do patients and families meet you, because they're Googling before you see you typically, unless it's an emergent situation. And how are you creating a relationship over time of trust? And can a digital tool make you more efficient? And if the system you're working in is getting serious about it, what you need to say is, you need to make my day easier. You need to allow me to take out redundancy and waste in what I say or what I do each day through a digital tool that serves and gives and positions a patient and family to like me more. Because you're probably really likable. And I think a digital tool can help you do that. I want to just get to a couple things at the end, but I'm just going to cruise through how you, ultimately, who has a LinkedIn profile? Yeah, That's good. Everyone should have one. I mean, only because it takes about 15 minutes, and because Microsoft owns it, and their search engine optimization is so high with LinkedIn. Sorry, these slides don't. Sorry, I'm like confusing you because I'm talking about two different things. But go and do that. I mean, you have a bio probably with the organization in which you work that they control, but go and tell the world who you are. Acknowledge who you work for. Don't be a moron. Like, just don't be a moron in work, and then don't be one online. Right? Be respectful and thoughtful. And I didn't get into the ethics of HIPAA, but you need to strive way higher than HIPAA. You should not share anything personal by time, by information, by gender, by timestamp. This is not about telling someone else's story. This is about telling your story. And connecting that way. But I want to buzz through this because there's a couple of things just right at the end. This is just kind of how to use. If you do go, is anyone using Twitter professionally in the room? And Facebook? Does anyone use Facebook and have a Facebook page? Yeah. So that can be the kind of thing that your organization could support you with. They can't get to your private account. You can kind of share information, but it depends on your role. And then there are these lists on Twitter, but I'm going to buzz through that. And then just in the sake of time, even though I've used almost all of it. One thing I'll tell you, the anti-science temperament right now across the country, I think, has really changed things. And this group is a group out of Pittsburgh called Kids Plus Pediatrics. It has a really strong social presence and a really strong engagement and a huge part of the market share in Pittsburgh. But recently they posted a bunch of information about HPV and flu vaccine, and they got completely pummeled by the anti-vaxxers, and they went and they attacked their Yelp page, drove it down to a 1. People from all over the world, so they could see, they were like people in Singapore, right, driving down their Yelp score that clearly wasn't actually engaging. So it's an interesting time in some ways to be a voice for science online. But I'll just conclude here that, patients want their data. It is our job to be as good as Domino's Pizza, right? I can order a Domino's Pizza, and I can track that pizza till it hits my door. And yet, someone cut out cancer from my leg, and I didn't know where that biopsy was for 3 days. And yet I know where my stupid Domino's Pizza is, right? So I want my data. I want to know where that tissue is and what's happening with it. I deserve that. I deserve that on behalf of my children and my mom and my family. And anyone who takes care of me, it's not their data, it's mine. But I am so thankful for the people who help me understand, just as everyone is so thankful for you in helping understand. But peer-to-peer healthcare is real, and how we learn. Patient communities are real. We've experimented with Smart Patients, which is a group where we've done that in small communities where we introduce parents to each other, where we can look as an organization and say, what are they asking? Where are they learning? What tools are they hacking? And how are we not serving them, and respond to it? But we're not there. We're not policing. We're just listening when they let us. Improve Care Now, which probably many of you know about, is a community that was really built out of MIT Media Labs, but also partnered with Cincinnati Children's, of saying, let's take an inflammatory bowel disease community, patients, families, social workers, doctors together. Let's look at who's getting healthier faster, and then let's share that with everyone so that we can follow those best practices together. And I'll end with this. Dr. Eric Topol, a cardiologist, he's the editor of Medscape. He's an inventor. But I believe him and think that he's right here where he says, patient data ownership is likely a future civil right. So let's get really serious about making sure patients and families have what they want when they want it, and let's conform and be those willow trees moving forward. Thank you so much for all your attention. And
Thank you. I think we have time for one question. Anyone?
Thank you so much. And I'm obviously a huge fan because of the liver transplantation. I've heard your presentations and everything. And one of the things that, as all the different transplant centers, and I think every pediatric hospital wants to do, is kind of the support. How do you link with all the different departments, with all the different subdivisions? Like, do you meet, weekly, or do you meet once a month? I know that you've done a lot of work with the liver team, but I also, from what you present today, you really interacted with almost every either subspecialty or primary care. So how do you, as the chief of information, or how do you keep all the pediatric department integrated?
Yeah, well, I don't. I mean, let me be honest, right? So I'm trying. One of the big challenges has been we've had a lot of executive leadership transformation and change. We have a new CEO. I'm on my 3rd chief information officer at the organization in just a few years. So taking an idea, building a pilot, having it be successful, and then creating an enterprise solution in the kind of in the kind of institution language is really challenging. But I'll tell you, any innovation, if you have, like, I haven't said to virtual handshake that we've never had anybody say no. So when people learn that they might be able to capture what they know and deliver it to patients and families, have their time be a little bit more efficient and have maybe a little bit less of that onerous kind of rote stuff being shared, nobody says, no, I don't want to do that. The big challenge, right, is funding the team that operationalizes the work, because it's just work to change up how we do anything. So what I've done, like the liver transplant work really came about, and that whole digital journey that we're trying to basically open source and give to everybody across the country and say, let's figure out how every center could use the same one. The split community, right, which is the national organization that looks at the quality and safety around liver transplantation, and the stewards of those organs, like, dump it all in the same place, do the same thing. And I said, I built it in a way that you can skin it. I mean, you guys can take it. You don't have to have Seattle Children's videos and logo. You just get rid of it immediately. You can take our kindergarten curriculum and then iterate it yourself, right? But across the organization, I'd say, if you're doing innovation pilots, find people who are enthusiastic and passionate. They will serve you, and it will happen. And so we've picked kind of strategically different pilots. Two things I didn't show you. We're building an app right now with an otolaryngologist just about to launch, where we said, after number one surgery for children in the United States is tonsillectomy, adenoidectomy. We basically have an opioid crisis across the United States, and yet we give them 30 prescriptions for oxycodone when they leave. We don't know how many they use. We don't know how many they need. We have a really clear clinical pathway around alternating over-the-counter medicines for pain control postoperatively. We just built an app that we're launching this month that we built in partnership with our otolaryngologist, our family resource center, and our patients and families, that now does a couple things. Everything that we've given them on paper is digitized. It gives them the same pain scale that they decide as a tool to say, do I need to use oxycodone or not? They log their ibuprofen, they log their acetaminophen, it nudges them and reminds them in that alternating schedule of every 4 hours of using that med, in the hopes that if we get ahead of the pain curve, we give acetaminophen and ibuprofen at 4-hour intervals, and then they log how much oxycodone. We can figure out how much oxycodone extra are we putting in the population, and we probably don't need 30 doses. And frankly, the otolaryngologists don't even know how much families use, so we're going to get information back. But we're doing it because we're checking two boxes. We're saying, I'm going to build something that patients and families will help them, and I'm going to build something that will help us as clinicians, this kind of dual centricity. So we built that app. We're also building an app right now that we got with an outside group called PRISM, which is a curriculum that's been studied in terminal cancer patients and in diabetes patients of mindfulness, goal setting, and experience scores. Children with terminal cancer at Seattle Children's have been exposed to this bedside curriculum now for years from an oncologist who studies resilience, and they have self-reported improved resiliency scores and quality of life scores. That's the kind of stuff like nobody pays for in healthcare. We got an outside firm to donate that, but now what we're trying to do is say, we built this app, which I'm happy to show any of you, and not just using it in cancer patients and diabetes patients where we've studied it. We're going to try to give it to everybody when they come to the hospital, because everybody could do a little deep breathing, and everybody could do some goal setting and some gratitude finding, and frankly, ushering that data across it. So what I try to do with these little pilots with enthusiasts, I try to take those pilots, and then I have a new chief information officer that just started this week. So take it and then say, what's worth its weight, and then how do we explore it across the org? But it's that I've got this little team and who kind of work frantically in the small ways. And there's nothing wrong with little solutions and little innovations. It's just making sure that you have an organization that's listening to you, and typically what I'll do too is say, what is the strategic goal of the organization this year, and what can I check off in my pilot that serves that, so that somebody, when I check that box for somebody, we recognize and realize when we're putting information about dosing meds and opioids, we're using our own intelligence from our pain pathway, and we're just digitizing it so it's more discoverable, as opposed to the pieces of paper that get shoved in the back of the car, and then parents go home and freak out in the middle of the night and don't know what to do with their pain meds. In doing that, can I check off that I'm looking at the safety and quality of my patients, that I'm using the clinical standard pathway, that the pharmacists are involved in it, and then ultimately that I'm asking the right questions to show that there has been a nudge in the improvement, so that hopefully the organization uses operational funding, or we use outside funding to continue to use it, so that you can use this. My goal is we can build this app after TNAs, or we can build this app after appendectomy, or we can build it after any postoperative, and that here at Primary Children's that you could use it too. I mean, our challenges in Seattle are not unique, nor are yours usually. So I don't know if I answered that.
I could listen to you all day, but we do have to end, and we appreciate your time and your thoughts, and please join me in thanking Dr.
Thanks so much.
Swanson.
Yeah.